Welcome to NSG 222, Study Session 4, Inflammatory Response. Introduction. This study session introduces you to pathophysiologic mechanisms which occur in response to injury to the body cells. Injury to body cells may be lethal or sublethal. Lethal injury leaves a permanent damage to tissues, while with sublethal injury, repair and regeneration can occur. You are likely to encounter patients with these problems in your practice. The goal of this study session is to assist you to understand how these conditions occur and how the body responds to these injuries with the process of inflammation. Learning outcomes. At the end of the study session, you should be able to describe the inflammatory response, pathophysiologic mechanisms of cell injury. Explain the stages and types of inflammatory. Highlight nursing interventions to manage inflammation. Inflammatory process. Inflammatory process describes tissue and blood vessels reaction to injury. Sequential reaction to cell injury occurs before adaptive immunity is fully established to dilute and neutralize the inflammatory agent. In other words, inflammatory response is the body's non-specific response to tissue injury caused by trauma, bacteria, chemical, or heat. Inflammation and infection are indications of the presence of foreign substances in the body. Signs of inflammation. The primary signs of inflammation are redness, heat, pain, swelling, loss of function, pulse. 1. Redness, erythema, from increased blood flow to site of injury. 2. Heat, resulting from increased metabolism and blood flow in the area. 3. Pain, as a result of increased pressure on pain receptors in the site of injury. 4. Swelling, accumulation of increased interstitial fluid and leukocytes from the circulation. 5. Loss of function, as a result of pain and swelling. 6. Pus, accumulation of purulent exudates as a result of infection. Stages of inflammatory process. There are 4 stages of inflammatory response: vascular response, cellular response, formation of exudates, healing. You would be taken through each phase of the processes. Vascular response. The vascular phase occurs immediately following injury. It involves a transient vasoconstriction of the local arterioles in response to the release of histamines and other chemical mediators. This is followed immediately by vascular dilation, vasodilatation, hyperemia, increased blood flow to the area, which raises filtration pressure within the vessels. The chemical mediators cause increased permeability of the capillaries and therefore enhance movement of fluid from the capillaries to the tissue spaces. Because the fluid contains plasma proteins which exert oncotic pressure, which further pulls fluid out of the blood vessels into the interstitium. These processes are associated with redness, heat, and swelling as signs of inflammation. Tissue becomes endematous. Fibrinogen, a plasma protein, is activated to fibrin, byproduct of the injured cells. Fibrin strengthens the clot formed by platelets. The clot traps bacteria to prevent spread. Cellular response. The blood cell, mainly the neutrophils and monocytes, are mobilized to the site of injury. The blood flow to the site is slowed with increased viscosity of the blood. The following processes are activated to facilitate the movement of neutrophils to the site of injury. Margination. Neutrophils and monocytes move to the inner surface of capillaries. Diapedesis. Amoeboid movement of the neutrophils through the capillary wall to the site. Chemotaxis. Directional migration of WBC along a concentration gradient of chemotactic factors, substances which attract leukocytes to the sites. The white blood cells, WBC. There are different types of WBC, and each of the white blood cells has specific roles fighting the offending organism. They include neutrophils, monocytes, lymphocytes, eosinophils, basophils. 1. The neutrophils. The neutrophils are the first group of white blood cells to arrive at the site. This happens within 90 minutes of injury. It initiates the process of phagocytosis, destroying the bacteria and other foreign and damaged cells. The neutrophils possess a short lifespan, 24 to 48 hours, and therefore are destroyed by bacteria as well. This results in accumulation of dead neutrophils in the blood. In response to the physiological need for more neutrophils, the bone marrow produces more into circulation to keep up with demand. Immature neutrophils, referred to as bands, are found in circulation. Note that mature neutrophils are termed segmented neutrophils. Increased number of band neutrophils is termed a shift to the left. This is common in patients with acute bacterial infection. 2. The monocytes. The second group of WBC to appear at the site of injury are the monocytes, appearing within 3 to 7 days of injury. There are also phagocytic cells, which are attracted to site by chemotactic forces. Monocytes transform to tissue macrophages upon entering the tissue spaces, and phagocytosis occurs. The monocytes clean and prepare sites for healing. Monocytes have a longer lifespan than the neutrophils and therefore stay in the tissues as multinucleated giant cells. Giant cells phagocytize cells larger for the macrophages. Giant cell forms granuloma, which is encapsulated with collagen. Example is tuberculobacillus. 3. The lymphocytes. The lymphocytes are the last set of phagocytic cells to arrive at the site of injury. They initiate humoral and cell-mediated immunity. 4. The eosinophils. They perform selected roles in inflammation. Eosinophils are released in large quantity in allergy and parasitic infections. They release chemicals which the control effects of serotonin and histamine, chemical mediators. They are involved in phagocytosis of allergen antibody complex. 5. The basophils. The basophils carry histamine and heparin on their granules, released during inflammation. Bind an antibody, immunoglobulin, secreted by plasma. Binding IgE triggers release of histamine and vasoactive agents from basophil granules. Chemical mediator or inflammatory mediators. The following chemical mediators play significant roles in the process of inflammation: histamine, serotonin, kinase, bradykinin complement components C3A, C4A, C5A, prostaglandins and leukotrienes, cytokines. Complement system. The complement system is a group of at least 20 circulating plasma proteins which are produced in the liver. They are activated sequentially. The complement system constitutes a major mediator of inflammatory response. Sequence of complement system. The numbering on the sequence reflects the order in which they were discovered. The sequence of activation is thus: C1, C4, C2, C3, C5, C6, C7, C8, C9. It should be noted that some components have subparts which are denoted by the lowercase letters, e.g. C3a, C3b, and C5a. Primarily, the component C1 is fixed to an antigen-antibody complex for activation. Thereafter, each activated complex can then act on the next component, thereby creating a cascade effect. Functions of the complement system. Cellular lysis, opsonization, making antigen more susceptible to phagocytosis, enhanced phagocytosis, increased cell permeability, chemotaxis, inducing phagocytes to antigen, agglutination, clumping of antigens, neutralization of viruses. Activation of complement system. There are two basic processes involved in the activation of the complement system. These are classical pathway and alternate pathway. Classical pathway. Antigen-antibody complex activates C1, first of circulating complement proteins. Fixation of component C1 to an antigen-antibody complex. The IgG and IgM are responsible for fixing complements. Alternate pathway. Complement is initiated by release of bacterial endotoxins and begins with C3, C5 through to C9. Complement activation increases phagocytosis through opsonization and homotaxis. Arachidonic acid metabolite. Arachidonic acid is the 20-carbon unsaturated fatty acids which are found in the phospholipids of cell membranes. The release of arachidonic acid results in production of prostaglandins through the cyclooxygenase pathway. Prostaglandins PGD2, PGE2, PGF2, and PGI2 induce inflammation and potentiate the effect of histamine and other inflammatory mediators. The release of arachidonic acid through the lipoxygenase pathway results in the release of leukotriene. Leukotriene LT, C4, LTD, LTE are called slow-reacting substances of anaphylaxis (CRSA). They cause slow and sustained constriction of bronchioles, important inflammatory mediators in bronchial asthma and anaphylaxis. Exudate formation. The type of exudate seen depends on the tissues involved and duration of inflammation. The exudates may be any of the following: serous exudate, catarrh exudate, fibrinous exudate, purulent exudate, hemorrhagic exudate. Serous exudate. This indicates the presence of low amounts of cells and protein. The exudates resemble serum. This can be found in skin blisters, pleural effusion. Catarrh exudate. In inflammation process involving mucoid cells, running nose, upper respiratory tract infection. Fibrinous exudate. Increasing vascular permeability, excessive fibrin leaking into the interstitium. This causes tissues adhesions. Purulent exudate. Containing pus and composed of leukocytes, WBCs, microorganisms, dead or alive, liquefied blood cells and tissue waste, furuncle void, abscess, cellulitis. Hemorrhagic exudate. Rupture or necrosis of blood vessels walls, hematoma. Healing process. This is the final phase of inflammation. It consists of two processes: regeneration and repair. Regeneration. This describes the replacement of lost tissues and cells with same cell type. The rate of regeneration depends on cell type involved in the inflammatory process. Examples: larval cells. Larval cells are constantly dividing, therefore regeneration is rapid, e.g., skin, lymphoid tissue, bone marrow. Stable cells. Stable cells regenerate only when the cells are injured, e.g., liver, pancreas, kidney. Permanent cells. The permanent do not divide, are half of cell cycle, e.g., neurons, skeletal or heart muscle damage can lead to permanent loss. Repair. Repair is the replacement of lost cells by connective tissue resulting in formation of scar tissue. Repair may occur by either primary intention, secondary intention, or tertiary intention. Types of inflammation. 1. Acute inflammation. Healing in acute inflammation occurs in 2 to 3 weeks with no residual damage. 2. Subacute inflammation. Subacute inflammation possesses the features of acute inflammation but lasts longer, e.g., effective endocarditis. 3. Chronic inflammation. In chronic inflammation, the process lasts for months and years. The causative agent persists or occurs repeatedly with tissue destruction, e.g., tuberculosis, rheumatoid arthritis. Nursing interventions to manage inflammation. Inflammatory process requires supportive care, which include the provision of comfort measures to relieve pain and promote rest. Specific interventions following the acronym RISE is useful. Rest. The affected area should be rested with reduced activity. Rest facilitates repair process by formation of fibrin and collagen across the wound edges without disruption. Application of ice or heat. Application of ice within the first few hours to control inflammation when pain and swelling is present. This causes vasoconstriction, thereby decreasing swelling, pain, and congestion at the site of inflammation. This is followed by heat application to reduce the accumulated waste product through vasodilation and increase circulation to the inflamed area. Warm moist heat may enhance the debridement of necrotic tissue is present. Anti-inflammatory agents may be prescribed if edema appears to interfere with adequate tissue perfusion. Compression. Direct compression over an injured part causes occlusion of the blood vessels and control of bleeding. When compression bandage is applied, it counters the effect of vasodilation and development of edema and provides support to the injured part. Use of compression should be with caution to prevent compromised circulation. Therefore, the nurse should assess the disturbed pulses and capillary refill. Immobilization while applying compression helps to reduce metabolic needs of the tissues and reduce further injury in patients with fracture. Elevation. The injured part should be elevated above the level of the heart to reduce edema through the process of increased lymphatic and venous return. Elevation of inflamed parts also reduces pain associated with blood engorgement. However, in patients with significant reduction in arterial circulation, elevation should be avoided. Summary. In this study session, you have learned that one of the processes of pathophysiological mechanisms which the body employs in response to tissue injury is inflammation. The process of inflammation begins with the vascular response. This is followed by cellular response and formation of exudates. The process of healing concludes the inflammatory process, and healing may occur by primary or secondary intention. End of study session 4. Thanks for listening.